the chat board here. All right, guys. So we are ready to go, and this weekend we are going to be talking about schizophrenia, and this is a very controversial group of drugs. It also has a number of things with regard to neuroanatomy, pharmacology, which is sort of interesting. But I will tell you, when I came through taking psychopharmacology, this was one of the most confusing groups of drugs because there were just so many phenothiazines, and all the drugs were very, very, very dirty. We didn't know, everything was going through the dopaminergic system, and so it was a major issue with regard to just learning it. And I'll probably repeat this weekend, but one of the things that you constantly found yourself doing when I was coming through was that you found several clinicians that would be like, okay, here is my top 2 drugs that I use, and if those don't work, then I go to haloperidol. And then the main thing was everybody worried about the emergence of EPS and tardive dyskinesia. So we'll talk a little bit about, we're going to start talking about the disease state itself, and there's still a lot of debate with regard to specific mechanisms and so forth. It is a complex disease and can be very difficult to treat. As in the past, what I've done is on the slides, you should have red slides, the red areas, which would be indicative of what you need to study for. And then we'll, so that'll be sort of your study guide there. And I may emphasize a couple other points as we're going there too. All right. So when we look at schizophrenia, is there, first of all, there is a tremendous misconception, I think, by the lay public. Part of this has been generated by misinformation. Part of this has been generated by sometimes depictions of on media, on television and movies and so forth. But this is also one of those diseases where that everybody sort of, we used to be so concerned about getting the diagnosis with schizophrenia because the drugs that we had were such so very unpleasant to use. And also the issue is that people thought so much of extremes and thought that pretty much when people developed schizophrenia, one of the major issues was going to be that these people almost had to be institutionalized, that they couldn't function normally. This is also one of those diseases which, when you look at pathology, we find that pathologists for many years always wanted to, like have a common mechanism. And it took for a number of years for them to recognize, even with hypertension, that which we understand a lot better than some of the mental diseases, to realize that these there may be a number of etiologies associated with this. So we will define schizophrenia as a syndrome with many possible etiologies. What we typically are going to see is that it is going to be characterized by the scenario of, I'm trying to get my pen, I'm still struggling with regard to trying to get used to using the pens with Zoom and stuff like that. But typically what we see is disorganized and bizarre thoughts. We see some delusions, inappropriate affect, hallucinations. And you can imagine that with these type of components is basically this can greatly affect the social functioning and cognitive deficits that would show up. So what we have found is that basically, especially the new drugs, have been very good with regard to um, helping manage people to regain social functioning and to actually carry on relatively a pretty good a pretty good situation if they're medications. Both with bipolar, which we'll talk about the next weekend I meet with you guys, both with bipolar and schizophrenia, one of the big issues we run into is making sure that they manage their medications, and we'll talk a little bit about that. I'm just curious. You guys are a little bit young, but do any of y'all remember pretty much the pretty much the situation we ran in with people, especially with schizophrenia and sometimes even with depression and other, where that especially older people, the idea was primarily just to sedate them so that they, we saw a lot of Thorazine being used and some other drugs that were really designed to just pretty much um, make sure that they stay put. So we used to see a lot of this where people would just use a lot of drugs with a lot of sedating properties. So I think some of you may have probably remembered, yeah, the Thorazine shuffle. And, we used to see this a lot, as Geraldine, as you mentioned, with this in some of the state hospitals. But we also saw it, in some individuals where, mom or dad or grandmother or grandfather basically had to move in because they needed to be, managed. And we saw their caregivers a lot of times, the situation. And one of the things that we saw was that they, I'm trying to take care of my kids, I'm trying to work and everything like that, and I can't worry about, grandma wandering off or mom wandering off. So the idea was give them a lot of Thorazine there. And so that can be that, and that sometimes still pervades our the thinking when you're talking about individuals. Some people are like, now when you mention schizophrenia diagnosis, one of the concerns that they have is that is this just going to just sedate them up and they're just going to be sort of a vegetable. Let's see. All right, so when you look at the clinical symptoms of schizophrenia, and I noticed I spelled schizophrenia. It's the first time I noticed that slide was wrong. We have the positive symptoms, the negative symptoms, and the cognitive. And Abdullah, I think with Omar, he went over the basic pathophysiology. We're going to go back over some of the general concept. We're going to go back over some of this before some of this, and we're going to reemphasize it, how the pharmacology fits in on it there. So when you look at schizophrenia, one of the things that we've seen for years is we've had we talk about positive and negative symptoms, but we also have some cognitive deficits, and sometimes those are those can be sort of masked by either the positive symptoms. But one of the issues that came into play was that we have both positive and negative symptoms. And in making the treatment, what we found is some of the older drugs were minimally affecting on some of these. So that's what makes this disease somewhat complicated, is that we have a numerous symptoms that depending on what the particular symptom is, sometimes the patient may not see a big issue, but sometimes the caregivers or other people around them will see this. And we had, for a long time, drugs that had minimal effect on some of these symptoms. We're going to go into that in a little bit more detail. When you look at the epidemiology of schizophrenia, one of the things that I don't, emphasize too much about the epidemiology, the incidence and the prevalence and stuff. But one of the things that I do want you to be aware of is that it is probably one of the most debilitating chronic mental illnesses. And in fact, the World Health Organization has frequently put it in the top 10 that of illnesses that contributed to the total global burden of disease in the world. When you look at it, it is an issue of affecting, some people have estimated about 1% of the population. Typically, the onset is between 17 and 30. Keeping in mind when we're looking at these onsets that sometimes the onset could possibly be at an earlier age, but this may be masked by people's perception of this just being a maturing process. We do see that that men tend to develop the disease, and again, some people have argued with these statistics on the men with regard to that men were more likely to potentially be aggressive or be identified more frequently than particular females. And we do see that women tend to be diagnosed a little bit later in life. So when you look at, especially like the World Health Organization, and most of you, I think, have an appreciation for this. Let me, my slide jump there. Taking a look at how these symptoms occur. So, looking at a person, just their normal things that they have to function at. We have social, we have their occupational. We include occupational sometimes, since I'm at a university, we include a lot of times under occupational, we include their school. Because we tell our students that, when you're a student, your occupation is being a student. But this can affect their work, this can affect their interpersonal relationships, or their ability to take care of themselves. So many of the people, when they're looking at this, that what they're basically doing is they're focusing on, really sometimes older people about taking care of themselves. But we do see people that are much younger that are that do have some issues with this that come into play. My situation is I've had students that have been diagnosed as schizophrenics and had problems associated with them in the middle of their studies, issues coming up, and these have ranged everything from creating a barrier to their learning to an issue of having them to in sort of miss class or having to deal with some personal or things like that have come forward that may pull them away from what they're doing. Plus cost of medication, cost of therapy, all of that can come into play. One of the big issues that I run into with students sometimes is being able to, I'm dealing with a student right now that my concern is, it's not just schizophrenia that's going on, but my concern is that he has a substance abuse issue, and then basically we got schizophrenia. And one of the things that we're dealing with is, unfortunately, he has chosen a therapist who is not experienced in treating healthcare professionals, which creates another issue. We just got an assessment back on him, and I hated to say, but it was a very, very poor assessment. It was not a complete assessment, and there's a recommendation, which is this bare minimum. And the reason this individual, he went against our recommendation of who to go see, because he went to the place that he thought was the cheapest. And he does not have a long way to go. And as a result of that, his idea, I think, is I just need to get through probably another, half a year or 3/4 of a year of school, and then I'm out from under this. So I'm dealing with that. And I am not sure that the therapist has a complete picture, because one of the things we already have is, prior to this assessment, we had done numerous missed meetings with the therapist, missed appointments. When you look at some of these things, you can easily see how these could affect them. For example, the positive symptoms, and I can guarantee you will get a question with regard to differentiating positive versus negative symptoms. But the positive symptoms, we have delusions, hallucinations, disorganized speech, catatonia. The negative symptoms, we see alogia, avolition, and hedonia, affective flattening. Mixed in with this, we can see cognitive symptoms. In fact, we've had students in the past where that we first recognized there was an issue because of their ability, their learning ability has been an issue. And so when we sent them in for assessment for a learning disability, we actually discovered they were schizophrenic. The affective and symptoms sometimes, the dysphoria and the depression, a lot of times we've seen individuals that have been diagnosed with, as misdiagnosed, I should say, where that they've been diagnosed with the depression. And the other aspect is, I mean, if you look at it, the depression and affective flattening, and even some of the stuff like anhedonia and those type of things could easily fit into a diagnosis of depression. So sometimes the individuals, their perception is more of an issue of if it's more depression unless they start having these delusions, hallucinations, and things like that. So when you look at treating schizophrenia, this is not an uncommon situation. A lot of times the precipitating issue may be acute agitation. Now, again, if the presenting situation is the depression and more of those negative symptoms, sometimes what we can see is they get treated and are, diagnosed as being depressed when they're actually maybe schizophrenic. But what we often see is we get acute, it's not an uncommon thing, is we get an acute agitation, which prompts a visit to the emergency room, the ED. Sometimes these patients I have a friend who works at the hospital, a guy that I do Krav Maga with. You guys may have heard me talk about him. His nickname is Pookie, and he sees this all the time. Is basically they show up for acute agitation, they're put in inpatient for a while, they stabilize, move them to outpatient care, and get them to a maintenance thing. And then one of the things that we have is relapse. Part of that relapse can be improper diagnosis. Part of that relapse can be a improper medication. Part of the relapse may be due to noncompliance. Some of these patients and even their caregivers are like, and especially when the new meds were out and were expensive, the idea we would see is that they would quit taking their meds when they started feeling better. The other thing that you've got when you have this relapse, or even the initial thing, there we go. My mouse wasn't clicking it. When you look at what's involved with schizophrenia, take a look at where all these costs may actually come up. If you start at pharmacy, paying for the meds. Now, granted, one of the things that's helped over the past few years has been a situation where that we've gone to a lot of generic drugs. So that has helped cost. And by the way, I'm going to tell you guys a little bit. I'm going to go over this slide, and then I'm going to go off a little bit about combination therapy, because I'm going to tell you something that I just came across this year, which is sort of, or just a couple of weeks ago, which is sort of interesting. So anyway, pharmacy, we've got the cost of the meds. And so even with generics, we still have the meds. We may have to have some health care associated with their family burden. That family burden can be anything from, just the increased stress of dealing with individuals. It could be due to some of the problems that the individual has gotten into. Many times the agitation and some of the things that's happened can result in legal issues. So the family burden has got cost, both with time, cost, additional stress. Hopefully we have mental health care that's factored in there. Physicians, hospitalizations, especially if they go to the ER with acute agitation. We may be dealing with the police, the court systems, emergency services. Not an uncommon thing that emergency services get called in. Crime, the person is agitated. We may be dealing with an assault charge. We may be dealing with that. And then there's just that other miscellaneous situation. So when you look at this, and all of this can sort of feed off of the other. So for example, the hospital, you've got medical care, and you may be, the meds may be a little bit heavier, more costly coming out till we get them stabilized. We have the aspect of whether the family can get them to mental health. One of the issues that we run into is basically it has been really, really, really hard from a standpoint sometimes to get these individuals into treatment for mental health. And Jib, as you're saying, there is you do see compliance, and clozapine is a good, clozapine. We'll talk about this. That one has specific labs that will go through those the clozapine situation. That creates even a greater bit of clients. One of the biggest things is that we're seeing in healthcare in general is, for example, they like to set up appointments. And so here you've got these standing appointments. Something comes up where the person can't make it. Maybe it's a legitimate reason. Sometimes it's they just don't want to deal with it. Something else comes up or they don't think they need it. But then once they get out or miss an appointment and try to set them back in, sometimes that becomes a major issue. We also have clinicians that are get very frustrated. I'm sure a few of you've had some frustrations with this. They have some frustrations with regard to the patient constantly canceling or even dealing with the patient, who the patient's not being compliant with what you're recommending, canceling at the last minute. A lot of individuals, to try to avoid that, they will, if you cancel within 24 hours, then you're still going to pay for the visit. Well, they cancel in less than 24 hours, and then you can send them the bills, and they just, you've got that issue going there. But you see a lot of clinicians that just get very frustrated at dealing with these patients. So it does take a burden. The other thing is to try to think of a general practitioner managing a schizophrenic patient or even diagnosing a schizophrenic patient is a major concern. I mean, as frequently as they may see patients, it is going to be very hard for a general practitioner, really to manage it, because you can't just do check-ins just to make sure they're taking their meds. Have any of you had patients that are being managed by general practitioners, or maybe was initially diagnosed and initially managed? And what has been your general? I mean, a couple of you sit there. Is that basically based upon your qualified answers there that you've given me? Obviously, it has not been. What do you see the biggest issues with the general practitioners? I'll give you some experience. Yeah, wrong diagnosis and too many meds, not understanding the disease. So typically they're going to either, when they show up in the GPs, it's easily they're at one end of the spectrum or the other. And so many of the general practitioners, what they end up doing is either diagnosing at the agitation spectrum or the depression spectrum. And the other thing is, that's a good point too, Jib, is that some of them may not be certified with the clozapine. Autism, Jason, that's a good point there too. Too much medication or too little. One of the things with this used to be a real big issue, specifically with the older drugs, is I will give you an example of one patient that I was involved with several years ago. This patient was in a prison in the state of Florida and was being given the older, the older phenothiazines. And she was on trial for murder, and she accepted a plea. And they said that the question was she really cognizant and even understood what was happening? And the prison psychiatrist, who basically visited each prison like one day every month to 2 months, had put her on about 2 or 3 phenothiazines, not only phenothiazines, but a couple of other meds, but they were very sedating. And when they asked him, would her medications affect her ability to understand what was going on? He said no. When you looked at the medical records, what you found out was his only criteria for these drugs creating any problem was whether they produced EPS. So if the patient was not showing signs of EPS, then the drug was not creating any side effects. And through a number of his patients, he would have the note of no EPS, no EPS hyphen, no side effects. And when you looked at the nurse's notes, what you actually saw was a number of side effects. They were not EPS. But here was a situation where that we actually was in a hearing where that the lady was able to make another plea when she was not medicated. But even the nurses and the people in the prison ward would describe her as being sort of out of it. She was having a lot of anticholinergic, but again, the psychiatrist was the overriding authority, if you will, and that was his statement was she was having no side effects with the drugs because there was no EPS. So the points that you guys have brought up is really a situation is one, Jason, is there was been a big misunderstanding with regard to a lot of the pediatric population. That's why I made the comment earlier sometimes about the diagnosis usually 17 to 30, because we may have had instances of this. There's evidence that this may be occurring at a younger age. And autism, and it's really some of these diagnoses are based upon misunderstanding of the disease itself. And think about it, that you've got all of these different entities in healthcare that are being brought in, and many of them could be reduced significantly with a proper diagnosis and proper treatment. The main thing that I've seen, and sometimes even with psychiatrists, is basically in the maintenance phase of these schizophrenics is that a lot of times it's the typical med check. So they go in, they have a 15 to 20 minute meeting with the prescriber. Sometimes it is a psychiatrist. And the issue is basically, are you doing okay on your meds? Any problems? And very little discussion. So I've seen that occur too. Not everybody, but I've seen this happen frequently, with regard to both with GPs. I've also seen sometimes where what has worked, by the way, is that we have found sometimes we have psychologists who have good experience with this that will pair with a general practitioner that basically sort of oversees the meds, but the psychiatrist and the psychologist and the general practitioner work very well. Actually, one of the best ones we've had was a guy that got his pharmacy degree, then went and got his DO degree, and has done, basically did pretty well with managing people with schizophrenia and some of these other conditions because he had the pharmacology from the pharmacy degree, he had his medical degree, and he relied on the psychologist really from a standpoint of both with the diagnosis as well as the monitoring of the symptoms and stuff, and it worked. But those people are far and few between. So this sort of comes into play with again with the previous slide, is that you can easily see that these positive and negative symptoms. Again, what I want you to be aware of is make sure that you know what the positive symptoms are, the negative symptoms are. And the reason I say that is because when we get to talking about the treatment process, we'll be talking about where some drugs may treat one type of symptom and versus the other ones. The other thing that I want you to point out with this is we've touched on several of these issues. Let me give you a couple of things there. Is on these cognitive deficits, one of the things that I've seen show up here is basically this situation has risen its head in a couple of instances that I'm aware of with DUIs. The issue is the person has been on medications, and so one of the things though is the individuals may be undertreated, or even if they're treated and early in treatment, sometimes they have an accident, maybe because of difficulty of their executive function or their concentration. So they're actually at risk for driving. In fact, I just dealt with a case this last week, a 24-year-old that was schizophrenic, basically was just learning to drive, pulled. I don't know if you guys have. I'm sure you guys have seen these drivers, which is that that what happens is that they will move into to make a turn. So they go ahead and get into the oncoming lane to make that turn. This is what the girl did, and hit a truck head on. And so the problem was when they found out, they did her blood, she had a number of drugs, including some antipsychotics. The doctor that was treating her, I did not necessarily agree, because he had her on 2 antipsychotics and there was no rationale that I'm aware of. And also, he tended to change medications from a standpoint of too quickly. So he would put her on. So he had her on antipsychotics and he had her on antidepressants, and again 2 antipsychotics, and then he also had her on benzodiazepines. So my concern was actually social, with the substance abuse potential on this category. That was a big concern with me. But nevertheless, the issue was, it turns out, I mean, we had to go to court with this girl. We got the DUI dropped because she was not under the influence of these drugs. It was simply a scenario where that because she had them in her system, they were therapeutic and everything. And so we did get the jury actually went with us on that. But the reality of it, the girl is serving 16 years in prison because of some of the actions and things like that are that she ran into. So these are things that we run into. Another big thing, and Maribel, I'll get to those association disturbances in just a little bit, if you will bear with me. So the other thing with, the other thing we're running with the same girl is numerous interpersonal relationships, problems associated with a lot of people that created additional problems in her family, in addition to her family. Was fired from a couple of jobs because of difficulty in interacting with people. One of the things that they did, that they cited her on for thinking she was under the influence, is because this wreck ended up killing 3 people. And when they were talking to her, they just said it just seemed it didn't bother her. And it was really what it was, looking at the video, is that it was sort of a flat effect. And they were thinking somebody should be much more agitated or much more emotional, if you will, that fact that some people had been killed. So there was a lot of misunderstanding issues there. But one of the other big things that we're going to do, and we're going to talk a little bit about screening on this, is comorbid substance abuse. In fact, we have talked about screening a little bit, so we're going to do a little bit of review on that a little bit from a standpoint of that. So one of the concerns sometimes in treating some of these symptoms, people like to use benzodiazepines specifically. The other thing that sometimes we run into with some of the negative symptoms, I have seen, well, let me ask you guys, what drugs have you guys seen by people that are not familiar with the disease to treat some of these negative symptoms? And you can just give me a class of drugs other than antipsychotics. So think away from the antipsychotics for a minute. Okay, mood stabilizers, keep thinking. There's another group that is misused, I should say. Antidepressants, okay, y'all are still. Stimulants, that's the thing, is you see a lot of stimulants can be used here, the ADHD drugs. The idea is sometimes they're having difficulty concentrating. Sometimes they seem to have difficulty sleeping and things like that. And we actually see the stimulants being used. So fortunately, we're moving away from that. And that is a good thing. But one of the things that we have had is that has actually been an issue that has come up there too. Typically what you're seeing now is you're seeing a lot more, as you guys have talked about, is we tend to see them treating a particular symptom rather than the schizophrenia. So we do see mood stabilizers and antidepressants. Again, when we see, when the agitation presents, that is, or the hostility that presents, we usually will see this a lot of times where that somebody will, we can see this in domestic disputes. We can see this when they get sent to the ER and things like that. And a lot of times what they're going to use is basically Valium or benzodiazepines. And then they usually give them, like the girl I was telling you about here, the doctor basically sent her home with benzodiazepines, alprazolam. And actually what we found out from her, and this was by looking at her medical records, is that she was, she was pretty much, he didn't put her on a stimulant, but basically was giving her one of the, he was giving her alprazolam, but then she was using a lot of caffeine. So we saw that going back and forth. And when he first started treating her, he was treating her basically, he was just going back and forth with trying different antidepressants. Had her on a tricyclic antidepressant, moved her to something like Wellbutrin, had her on Buspar for a little while, and then he ended up with Seroquel and I can't remember, Risperidone, I think it was. So he had Risperidone and Seroquel, and fortunately, he kept pretty good records for her side effects, which helped us out tremendously. The biggest thing we saw was with the Seroquel, and I think he did give her sometimes Trazodone to sleep at night. So I couldn't quite make out from his notes. It appeared he was giving her the Seroquel to help with her sleep, but then he was giving her, he wrote a prescription for Trazodone. So was not real impressed with this doctor's choice of medications. Let's see, Kirsten. Yep, seen that quite a bit, and we'll talk a little bit about that, Kirsten, with regard to the nurse practitioners. We've got some very good ones. Obviously, you guys probably around there too. But I know that a couple that when I would go in, it was funny because I don't know if you guys have had this or not, but I've gone in and they just asked me, well, what do you want us to give? What should I give you? And in one sense, I'm like, okay, I probably know a little bit better than about the drugs. But on the other hand, it's a little disconcerting that the nurse practitioner is asking you what you want. And Jason, yeah, I've seen some of that data with regard to these ticks that may come up, but the big thing have preached around here in a lot of places that I've done is the concern with the putting them on the ADHD with the bipolar and kicking them into serious, very serious manic symptoms. And you know what's interesting with that, and we'll talk a little bit about this next week, but with the serious manic symptoms is sometimes parents actually are almost, they've seen the kid being very depressed. And even though the child goes into mania and has some serious mania issues, sometimes the parents actually are like that. If the idea is the kid's not being, is not that depressed, and for some reason the parent may even think that there is the less likely the child committing suicide and things like that, but they have no idea of the compulsiveness and stuff like that that can actually kick in there. So if you look at, people have tried to follow this, and this is sort of an interesting thing because when you see that the average age of diagnosis is 17 to 30 years, when you look at this, you can start seeing that people were recognizing, even back in the late 90s, that there were some stages of illness that were starting to show up before the age of 17, although this starts to show this. So basically, what they saw is that, when the graph goes up, it's pretty much they are healthy, and when it goes down is that the symptoms are getting worse, or the increase or decrease, So there was this premorbid conditions, they're not showing any symptoms. Then they describe this prodromal, where it's an area sometimes between the ages of 10 and 20, in which the individuals start to show, and it's not really clear what prodromal is, but seem to start showing some things when you look back. In fact, a lot of times with prodromal is you're looking back and starting to see some changes in symptoms, mood symptoms, and so forth. And then you see that you see the onset where the symptoms really get worse, and you get this deterioration, and then you sort of stabilize them. And this is sort of like, so the onset deterioration is really between 20 and 30, and then we get them stabilized. But even with stabilization, we do see a situation where there may be some relapses. So again, one of the things that I try to emphasize to people is with this disease, it's not sort of like people think of hypertension, where that once we get your blood pressure stable, it stays pretty stable for a number of years. As long as you're taking your medication, you keep your blood pressure stable. And if anything, we see your blood pressure slightly go up as you get older, and then we can sort of slightly increase your medication or tweak it a little bit and do fine. But with the schizophrenia, one of the things that you find is that we don't talk about a relapse in hypertension. We talk about a relapse where that there's a return of symptoms. And one of the concerns that you have with the relapse is when you factor during a relapse, let's go back to a couple of slides. Let's see if it allows us to go back here. When you factor with relapse, integrating all of these different costs that come into play, and especially think about during a relapse, somebody does something really, bizarre or absurd, which is not uncommon with schizophrenics, where that the police or the court system or even have to be hospitalizations. This could have a tremendous impact on, we see, lose their job. Healthcare professional, we may run into a situation where that they may be very limited what they can practice, or their license may be an issue, especially if we have, substance abuse. So there's a lot of different things that can happen that can create some major issues, and that's what we have to be aware of. Okay. And this slide sort of does it, is we do see, most of the time we do see, Maribel, I've seen the same thing is as they get there older, that the positive symptoms seem to decrease. That's what people are recognizing. And that's an issue that, so the question becomes there is, one of the things that we're looking at is there do we need to alter therapy on those? And that's one of the things, again, being dynamic. But that's one of the things that people have suggested is it's an age-related decrease in the brain action there. And Geraldine, this is a good case of what I was saying is you've got a person where client relapse killed somebody. And so when you look at, when you look at the cost involved here is that, because I've been called in on murder cases, several murder cases over my career. And a lot of times, so the big issue with the murder case when I get called in really comes into, does the person get the death penalty or does the person get life in prison without parole? And we get into this argument about the death penalty is cheaper and it would save cost to the prison system. And actually, I think there's been some studies that show that people that get the death penalty actually cost us more than people that are just put life without parole. But the biggest issue from this is that there is a lot of cost. I mean, basically, when you hospitalize, put somebody in a state hospital, that's a big issue. And also, they don't go into a state hospital, but then they lose their job and things like that. Sometimes think about getting back to the family burden that may have of the individual being able. I have a friend who's developed dementia with some schizophrenia and so forth, and he was a university professor. He has long since retired. He went through a divorce, and I think he had some schizophrenia that people did not, just because of who he was, it was not going to be a diagnosis that people would think of. Being a university professor, he was an agriculture with regard to meat science about growing cattle and stuff like that. Very prominent, very religious person. And So now he's not in a state hospital, but there is um, uh, he is in a home with limited access and so forth, and um, that is a big issue there. What we do see is that when people are discharged from the hospitals, a lot of times that is the initiation of drug. The other thing you could say is whether it's the reinitiation of drug therapy or sometimes a change in drug therapy. So we find that by getting them on the drugs, we can get them out of the hospitals. But what is the problem is many times people leave the hospital thinking they're cured. And so what we see is that they're unstable and they may be in remission. Some people have suggested 30% of the people may leave that. Um, and are in some hospitalization. And then you've got a majority of them are in varying degrees of recovery. Typically, when they leave the hospital, they're initiated in the maintenance phase. But we do see high rates of relapse. And as one of you mentioned earlier, I'm going to move closer to the mic to see if that's there. I'm seeing see if that works out a little bit better. I think we're getting a little bit of delay, which is happening there. And hopefully that'll get better. But the biggest thing that we find is that we have to recognize that relapse rates are high, which gets back to our issue of compliance. And remember with compliance that it can be that the patient is maybe too sick to remember to take the meds, or it can be that the patient thinks they're cured, or sometimes you find that sometimes the caregiver doesn't want to give them the meds. Um, that is a sad situation, Maribel. You do see it looks um, that they are stabilization, and then you quickly see that, and but there's is going okay. They've made so much progress, and you just have that gut feel once Steve or step that is. Yeah, we're gonna do the break, and when we get back, I'll uh, question I think that I had. Is the sound any better now?
A little better, doctor.
All right, let me check this and see if is it better now.
Yes.
Okay. All right. Hopefully that's. I was messing with the volume and I may have turned it down too low, so hopefully it'll stay in. Okay. One of the things that we see when we talk about chronic disease, and I'll be talking to you guys about chronic diseases down the road this semester, but what we find is people with chronic diseases, we always think about their quality of life. And one of the things we see with schizophrenia is that even that generally their quality of life is going to be less than a lot of other people with other chronic diseases. We do see a risk of suicide. It's been estimated to be about 10%. We do see a lot of problem with people maintaining a job. Obviously, if they have, sort of a breakdown where that they are agitated at work or something like that, it's easy enough. People will just want to fire them. Sometimes the diagnosis of schizophrenia, if people find out those people are schizophrenic, basically it puts a stigma on them. This is improved. This next statement is that we do see that with the old, and I leave this in here because I want to emphasize this. This came from an article that was published in '96, and one of the biggest things that we saw was movement disorders were present in approximately 2/3 of patients that were on typical antipsychotics. Okay. Now, the reason this may have improved is one, we've had a decrease in the use of these typical antipsychotics. And also, we've had a lot of education with regard to the individuals that may be on these so that they are being monitored a little closer and that we're watching the dosages. But we have seen a reduction in general with the movement to using the new antipsychotics. But then, as I've said before, this paper noted at 98, we do have a high relapse rate. With the old antipsychotics, the typical drugs, the side effects a lot of times, I mean, people would, when they start developing tremors and dystonias and things like that, they would quit taking their medication because a lot of times to them, the signs or manifestations of the schizophrenia, which may come and go, may be more acceptable to them than some of the dystonias and so forth that may occur. Okay, so this is a good place to take our break. Let's come back at hour, and then we're going to talk about handle.
Doctor,
When we
your
get
voice
back,
was again.
I think it.
Your voice was again going out. What time classes resume?
Let's around with the mic
I
here
don't
to
have
see if
any
there's
sound.
anything I can do here. I think it is banned. Let's see if y'all can hear me. Am I coming through okay?
Hear you, doctor.
Great. I got bumped off of Zoom. That's when, toward the end, I think that was a little bit of issues there. That's why I just, actually, I got tired of y'all, so I just logged off. So. Oh, listen to Jason there. He appreciates the honesty. So well played, Jason. Well played. All right. So before I continue on, let me address, I think it's Janelle's question about the associational symptoms. I was looking to see if I had a paper. Let's shoot that on there. But on the associational symptoms is basically a situation where that the words and the meanings are basically are just, they don't follow. So there's a problem there where that we see that the individuals that are just not.
I apologize, doctor, to interrupt. Could you try to go the next slide or previous slide to see there is something? Okay, now it's okay.
Okay, all right. So I was trying to get it to there, but basically the associated is where there's nonsensical associations between the words and the ideas that are characteristic. And I may still have a paper that I can send you guys on that, but it'll be, and by the way, most of these papers, unless I tell you that it would be something on the test, it was really more for your information. So if I bring things like that. All right, let's see if this will move me to the. All right. So we ended up with, let's talk about the issue with regard to the etiology of schizophrenia. There have been a number of different theories that have come up. There is always, with a number of these mental illnesses, there is a question of whether there is a genetic connection. And so genetics has been proposed as being one etiology. Another one is that something is happening during the perinatal stage where the brain has been injured. Some people have suggested viruses in particular can cause this. So with regard to that, and then some people have argued autoimmune disease. So when you look at these different causations, the problem is that a lot of times going back and trying to get the information that would allow us to do this or to make these is sometimes difficult. It's getting better, but if you think about it, and I've told my students in pharmacy this all the time, is when you are trying to follow back, especially in some of the older generations. You know, in my case, it would be like my grandparents, even my grandparents, but definitely my great grandparents. Is that you know, they would just simply say, well, you know, Uncle Joe was crazy, and that's about the best you could get. So. We would see also the other thing is, I don't know if you guys have seen this, but there are instances where that in some rural areas that anytime somebody has some mental issues, regardless of what the cause is they basically hospitalize them many times. Sometimes would require the local police authorities to come pick them up and carry them to those particular facilities. So a lot of times people kept it quiet, and it was only those things. So trying to link these things has been a little bit difficult, but with our new technology and stuff like that, we are getting some new information. So what we find is, here are some associations that we have found with regard to this. Is first of all, is there is an inverse relationship between socioeconomic status and the incidence of schizophrenia. So what we find is this relationship works in metropolitan areas, but seems to not work in smaller cities. And if you take out the lower socioeconomic group, then the relationship goes weak. So we've seen that. But what we do see, so there's been one observation that's come in and has been controversial. One of the things that makes it controversial is sometimes that it may stigmatize the lower socioeconomic group. We do see that there has been a genetic relationship that has been demonstrated. And so again, like with most genetics, the closer the relationship is, so the closer you are to the person that has it, the greater the probability. So I think there is some pretty good evidence that is suggesting that there may be a genetic link. When I pause and it takes a moment, it's because my slide's not going. But one of the things that, and I think I have a couple of papers that I'm going to make available to you guys, try to get them posted for you tonight, is these are some things that has come about, is that some people have argued there's a developmental error. Now, what we find is that when you go back and look at the data, you are many times reviewing data, you're dependent on other people, like, for example, looking at medical records. And so people have suggested that people that have schizophrenia, that when you look back in their medical records, that there's a higher incidence of perinatal complications. And they have, you know, have not been able to, or they've not definitively identified what those are. Basically, what they just simply said is that in the early developmental stage, if there were issues or complications associated with the pregnancy during this period, then bottom line is that those people that occurred or was observed in people that had schizophrenia. So again, this is secondary information that is there and creates a problem with regard to that. Okay, hold on one second, guys. Then there was a big issue, and this is with a lot of viruses. One of the things that happens is the reason viruses are. Does anybody have an idea why viruses may be named or identified with a lot of diseases, including mental disease? Anything that you know about viruses that would suggest or make them more likely than, say, bacteria or something like staph or something like that? This is sort of checking y'all's to see what you know about viruses. So, Jason, what I'm talking about is, what is it about viruses that may make them more of a candidate for producing these abnormalities? Okay. So Kirsten, you're probably the closest. So what viruses do compared to most bacteria is viruses actually get into the cell. Bacteria and all these other microbes get into the cell. But what they do is they get into the cell and they basically use the cell. I mean, think about HIV. One of the things that happens is it gets in and actually uses part of the cell's processing. So the thing that makes viruses a good candidate for producing these things is that viruses, in fact, that would be, let me make myself a note here. I'm at lunch. I think I've got a little short video that I'll give you for lunch just to sort of show you what viruses. But viruses actually get inside the cell, and there's a couple of things that viruses like to do. Is one, by getting inside the cell, it sort of protects them because the body has to attack the cell and kill the cell to kill the viruses. But many of the viruses, what they do is, and they will cross the blood-brain barrier and they can get into a lot of different things, but they get inside the cell and actually use the cell's biochemical mechanisms to reproduce and so forth. So they actually, whereas a bacteria may attack a cell and kill it, the virus actually gets into the cell. And so things like influenza, that is, people are exposed to influenza A, a lot of those. We find that viruses mutate quite a bit, so they're hard to track. But the biggest things, they get in the cells and they basically sort of parasitize the cells and use the body's own cells to multiply and to grow. And the fact that they're getting inside the cell and using some of the biochemical mechanisms makes them a good candidate for, potentially once they get in, to make modifications of the cell, which can result in altered. So one of the things that we find is that people have suggested that the cells may have abnormal myelination or neuronal sprouting, and it would make sense that a virus could potentially get in there and basically modifying or using the cell's own biochemistry, then that's an issue. The other thing that in treating virus infections is that they mutate quickly, but also they can hide in the cells, which makes it difficult for us to get some of the drugs in there. But it would make sense that a virus gets into the cell and actually modifies that cell's function. And that could basically account for maybe some abnormalities in myelination or how the neuron sprouts. So these are some things that have been, suggested that occurs with different viruses. There's been another model, which is called the biopsychosocial model, which basically says that environmental stresses alter your neurochemistry. We know that can occur. And their key point here is they say in susceptible individuals. We also say that there is a vulnerability stress model, which there's some sort of interaction between stressors and the ability to protect, the body's protective mechanism. All of these, whether it's genetic, viral, or whatever, keep in mind that A is that our body responds. And so it could be a combination of these. The susceptible individuals could be, for example, people that have a genetic predisposition. The susceptible individuals could be people that basically have a virus or have been exposed to a virus or been exposed to some perinatal stressor. So again, there's been a lot of research to try to identify specific etiologies, but we have been limited we're limited with just techniques. Although techniques now are improving, we have things that are there. But this next slide sort of emphasizes, some abnormalities. And what we're looking at here is this is just in general a neuron, okay? So one of the things is that there could be a toxic insult, which could be you're exposed to some chemical, some environmental component. And so up here, what happens is that you're exposed to this, or you have a genetic predisposition. So one of the things that can happen is the neuron is going to be affected where that it either becomes dysfunctional or it becomes or dies. So that has been one of the things that, remember, during the, during growth, we have a lot of pruning, we have a lot of remodeling of the neuronal system. So one situation could simply be that whatever it is, whether it's exposure to certain environmental toxins, whether you have a genetic insult or the toxin maybe attacks the gene. So the net effect is that we have these neurons that basically either become dysfunctional or they die. Okay, so that would be one way that occurs. Another thing that could happen is that one of the things we see is that neurons, as we're forming pathways and everything, is that these neurons will sort of migrate and we have some remodeling that occurs. And so, Geraldine, you asked the question there is, could the stressors be a psych trauma? Potentially. They're using just generic components because they're trying to look at, in this particular, looking at the models, they're like, what could occur that could cause changes in the neuronal system? And so one is that you get this insult. Another thing is that you can get that as the neurons are trying to form and sprout, that you don't get good migration. And so, for example, here they may be indicating that these neurons here would be what you would expect, but these neurons here are not, their pathways are not being formed, and so you get some poor neuronal migration and pathways that are formed. Another thing going down to the bottom there is that you may have that the synapses. There may be something, they describe it as an inadequate synapse selection, which means that you may not be able to develop those synapses. And if you don't have the synapses, that's where the neurotransmission is occurring. And so maybe there's not enough of those, or when they call it inadequate, it could be either not enough number, or it could mean that there's something wrong with the synapses. And then the last thing they have listed here is poorly innervated, which basically you can see all these different spines on these neurons here, where these seem to be, sort of blunted. So ultimately, what you're seeing is that whatever causes this injury, that there's an alteration in the neuronal pathways and in the neurons themselves, which can interfere with overall function of these synapses or neuronal pathways. Okay, so these are sort of like, we're spitballing and just going, all right, so what could screw up the pathways that could interfere with the neuronal transmission? So you can have the neurons dysfunction. What do you mean by dysfunction? That can mean a number of things. It could include several of these things we have here. Could mean the neuron is not firing. The neuron is not making enough drugs. There's not enough receptors. If the neurons die, that could interfere with it. That could be another issue there. So Geraldine, you asked with regard to it in the, does it have to be a history of pure schizophrenia, or it can be a family history of bipolar and other mental illnesses? I don't know if with schizophrenia, they have tried to identify specific things, but again, one of the problems in answering that question with some of the research has been that there are people that are bipolar that are schizophrenics. Probably you have more schizophrenics diagnosed as bipolar. And so I'm not sure that they have a direct answer to that question. Okay, so this is a pretty interesting model that Jarle got. I like this model, so make sure you put this slide in red. And the reason I say that is because this can explain some of the reasons the pharmacology works. Okay, all right. So let's go through this. All right, so we start off with they use Yarlagadda basically uses this term, early brain adversity. So what does that mean? That could mean several of the things we just talked about. That could be, perinatal trauma. That could be a genetic insult. It could be exposure to a toxin, whatever. Okay. So what his suggestion is, as a model of schizophrenia, is that whatever it is that causes this early brain adversity, the brain is exposed to, and it could be trauma, it could be, a lot of different things. Okay. He's not focusing on it. What he's saying, okay, I'm not going to really say specifically what this trauma or this adversity is. I'm just saying that early in development, there is something that interferes with the neurons or affects the brain. Okay. So what he says, that results in basically a NMDA receptor hypofunction. So what's happening is, because of this early brain adversity, we get a dysfunction, really a decreased reaction or decreased activity of the NMDA receptors. Okay. So what happens then is that results in a decrease in dopamine release. And that can then lead to, so I'm going to walk through this and we're going to come back to it. That can then lead to an excitatory burst, which can then cause calcium influx, moving down through, just following it through down here, calcium influx, and that can cause a phasic dopamine release. So we get a decreased tonic dopamine release, and that causes an excitatory burst. The net effect is calcium goes into the neurons. We start getting dopamine release. And then what can happen is that dopamine can do one of three things. Okay, before we go into that, let me come back up here. Now, this is sort of where he sort of builds in the other parts of this model. So what he's saying is, and this could be the susceptible individuals, that susceptible individuals are the ones that basically had this early brain adversity, which could have been genetic or stress or whatever. But then after birth, he's suggesting that as the brain is maturing, during that postnatal brain maturation, that the person is stressed. And that stress can also affect this dopamine and this excitatory burst. So he puts that it may be a susceptible individual gets early brain adversity, and then with a stressor later on in life, this is what sort of turns the system on, if you will. Okay. Now, with this calcium influx, let's look at what can happen. One thing can happen is, let's go this way. So one of the things that happens is that the microcirculation in the brain gets changed, that the calcium influx and the dopamine release alters the microcirculation. These are the small blood vessels in the brain. And that results in, moving on down this way, what that's going to do is, because the microcirculation is changed, I am not getting as good a blood flow, so the tissues may be hypoxic, and may also, when they become hypoxic, they may release reactive metabolites. Okay. Now, that alone could potentially result in the positive symptoms and the negative symptoms, but basically psychosis. And as the psychosis develops, that could feed back and cause more hypoxia, because when the psychosis occurs, what could be happening is basically the neurons are firing abnormally or dysfunctionally, but they're still firing, and they may create these reactive metabolites. And so that could contribute back to more hypoxia. This goes down through, and basically that can cause cell death. That gets back to the neuronal cell death we talked about earlier. But it can also cause ischemia. Now, when we're talking about tissue damage, we're talking all of this is up in the brain. Okay. Now, and this gets back to a comment that, let's see, before we took our break, I can't get it there, but someone made a comment about losing with each psychotic episode, there's a 1% brain loss. This would fit with that. So basically, when you get the ischemia, tissue death, that can lead into atrophy, degeneration, neurodegeneration, And when we get the neurodegeneration, those neurons are not going to release things like dopamine, glutamine, or nitric oxide. And that could also contribute to psychosis. But the atrophy could also, this neurodegeneration would also could result in cell death. So you form this sort of cycle that goes from that way, okay? Now, let's go to the other side, and I'll change pen colors, hopefully. Black, okay? So the other thing that can happen is when the calcium influx comes in, what we get is we're going to go this way now. So what that causes, calcium comes in, and calcium will cause the release of nitric oxide. Okay, nitric oxide is a very short, people refer to it as a putative transmitter, but it's very short acting, got a very short half-life. So the nitric oxide, when it's released, it causes vasodilation and release of reactive metabolites, which can also, they call it a pathological vasodilation. So it's something that's not supposed to be happening. That can cause a psychosis, which can also go back and cause more release of these reactive metabolites. And these reactive metabolites can actually result in cytotoxicity or cell death, which causes the atrophy. And then the atrophy degeneration can result in the psychosis. And then the third option is, went to the wrong slide here. The third option, we're going to change colors here. Let's get different ink color. It's not a wide, so I'm just going to have to go with this. Dopamine release actually can cause the psychosis. Circulation or yeah. So there is there with this on the things that is that multiple issues. Now, one of the things I want to point out is when we look at the bottom here, this is stuff we're going to talk about later on today and tomorrow. So what we find is with this model done is basically said this model explains why certain drugs work. So for example, one of the big drugs that we use classifications, dopamine block, look at you're looking at the so much today. I'm going to try to move in. That'll be better. But what I'm saying is that when you look at drugs that we find, the majority of them are going to interfere or interact with the dopamine receptor. So if you look at 4, it's got a little 3, you find that
Well, I guess we have completely lost Doctor. Okay, Doctor is back.
yeah, I don't know what's going on with Zoom. This is the first time we've had problems with Zoom. But what I was saying before I lost you guys is that basically the dopamine blockers have been one of the one of the major sites. And when you look at this table or this schematic here, you find this gives a reason why the dopamine blockers would work, okay, is by this phasic dopamine release, which can either result in the microcirculation changes or the physiological release of nitric oxide. Basically, by blocking that blocks these pathways, okay? So that works. But it also shows one of the drugs which we use, but it's like a fourth agent, fourth line agent, is calcium channel blockers. And if you see number 2 here, what we find is 2 would interfere here by preventing that calcium influx. So that would be a potential there. There is a suggestion that antioxidants would work, and that would be down here. NOS inhibitors, we really don't have any drugs that we are using. There's people looking at NOS inhibitors, and we have things that may indirectly act, but by inhibiting NOS, which is nitric oxide synthetase, that would prevent the formation or prevent the action of nitric oxide. But, and then the NMDA receptor agonist would be when we have hypofunction by stimulating. So we're going to be talking about these different things. But this chart is good simply from the standpoint of it gives us, in one sense, potential targets that we could potentially use to address this disease. So from that standpoint, it is a good scenario, okay? Now, the thing to remember is this. This chart basically is talking about efficacy, okay? So these are all potential targets that we could potentially develop drugs that would potentially help with this disease. What we have to keep in mind, and this is exactly what we ran into to begin with, we can have the most efficacious drug you ever thought of, that it works in every patient. But the problem is, what about the safety aspect of it? And that's exactly what happened with our initial focus here, is when we developed and found drugs that worked by blocking dopamine. Remember that the typical antipsychotics, the older conventional antipsychotics, all were blocking dopamine 2 receptors. 2 things happen. One is we don't have any way for a drug that we can practically give a drug to someone that would go only to where it would affect the dopamine in those particular sites where the problem is. The problem is it's going to block it in other dopamine sites too. And that's where we start getting the move EPS. So the fact is we found a target that looks great, but the point is that target, there are similar other targets or similar other sites that wouldn't be our target, but we can't deliver it that way. So that's what's happened with a lot of these drugs, is that although we found efficacy targets, the problem is we cannot get enough drug there without it hitting other targets. And as a result of that, it will be we have to deal with side effects. And even in early on, one of the things is quality of life, is even in patients that were treated correctly, the issue was that those patients, we had the side effects which made it bad. So put on your, just put on there to identify these general targets. I am not going to ask you, what I would ask you is something along the lines of how would you explain, is it an increase or decrease in dopamine? Is it an increase or decrease in NMDA? So the general concepts, I'm not going to ask you to go through each one of these components here, okay? And Aiden, I got your text message, and when we take our next break, I'll be sending you the questions for the morning session. Okay, now one of the things, this next table is, one of the things that we run into is we've gotten much, much more sophisticated with regard to our molecular biology. As we've learned that there's a lot of different factors on the molecular side. And I'm just going to go through this sort of just to highlight is the net effect here is that we see with schizophrenia that we're going to accept that there is an altered neurogenesis, okay? That altered neurogenesis is going to be central, okay? Now, we have done a number of structural studies and also some tests. And what we've seen clinically is that MRIs that have been done on schizophrenics have demonstrated that there is a reduction in the hippocampal volume, okay? So that's a structural study we've done. Functional MRIs have demonstrated that there is an impaired hippocampus activation. And then we've also identified basically that there are deficits in hippocampus-dependent cognitive functioning. So what we've seen is these are clinical observations is that there are hippocampal pathologies in schizophrenia. That is consistent with altered neurogenesis. So in the adults that develop it, we have the fact that we're seeing these hippocampal pathologies, those are completely consistent with something happening to alter the adult neurogenesis. We also think that basically these hippocampal pathologies would explain some of the delusions, the paramnesias, the cognitive dysfunction deficits. These are symptoms of schizophrenia. So one of the things that people have done is their idea has been, so what molecular things could occur that could alter these adult neurogenesis? In the previous slides, remember we talked about, when I first showed you the little slide with the different neurons, we said there was some insult, and then we saw these different things occurring. Well, one of the things that we see is when you look at different components. So they have BDNF, we have NOS1, WNT3, Reelin, NPA-S3. These are all acronyms. I'm not going to worry about you knowing what those are, but just look at this. So one of the things that we might have is that alterations in BDNF could promote the survival or could alter the survival of newborn cells. We find that changes in NOS could switch the cells or alter how the cells differentiate or how the cells migrate. We find that WNT3 could have a direct effect on it. We find that Reelin, if it's affected by some of these other components, then basically that could alter signal formation and produce, basically alteration in the cell structure. So all I want you to get from this is that we know that there are several things, several factors that have been identified that could alter adult neurogenesis. If neurogenesis is altered, that would explain alterations in the hippocampus. It's one of the sites that we would see. And if we cause the hippocampus to be structurally altered, that could explain symptoms that we see in schizophrenia. So again, one of the problems with looking at all of these components like BDNF and NOS1 and WNT3 and all these others is there's a very complex interaction between these components here. Two is one of the big issues that we always run into is this an initiation? Is this occurring in initiation or is this occurring in the maintenance of the disease? So is this a response, for example, the body has had in result of that? So what we've seen with this is basically that on a molecular level, we have identified pathways that could account. The real term is could account for altered adult neurogenesis, which could alter hippocampal function and result in symptoms associated with schizophrenia. So this is a good time to take our break. Well, let's come back at 5 after the hour. And what we're going to go through when we come back at 5 after the hour is going to be basically, we'll talk about some of the neurochemical hypotheses, and we'll cover that through our lunch break. And again, what we'll do is close to lunch, we'll break for you to take the quiz, and Aiden will also do the poll, attendance poll, and we'll go from there. Okay. All right. So I will see you.
Doctor, I might run the poll right now.
Okay. So let's plan on coming back, since you're going to run the poll. Come back about 6 minutes afterwards. Okay.
Okay.
Video, if you would post that on Moodle for the students.
Hi, Doctor. I just got them. They're gonna be posted soon, and I'm right now uploading the. I just wanted to check regarding the connection with you. I mean, if on a break we can talk over the phone, maybe it can help with something if this keep happening.
Okay, we'll check on that. We'll do. Okay, guys. So one of the things that I sent for Aiden to put on up for you, there is a 3-minute video you can watch at your lunch break, which is dealing with viruses. It's not specific for schizophrenia, but it will show you how a virus will invade a cell. And I think it's an animation showing how the virus sort of comes in and uses the cell, and that'll give you an appreciation for some of these mental diseases that have been suggested as having a virus. It gives you an appreciation for that. So let's go to the situation here with regard to specifically some neurochemical processes. We're going to, a big part of how schizophrenia is treated really focuses on how we're interfering with the transmitters and so forth. So we're going to go over some of these. We'll break for lunch, and one of the things that I'd like for you to do at lunch is maybe to look over a few slides on these mechanisms to just make sure that you've got them down, so that we can basically, if I need to go over something again after lunch, we can do that. So when we look at the different transmitters, the idea here is that people were trying to determine, we know that neurons are dysfunctional. We've got data and so forth, but even early on, one of the things that we see is that people were trying to identify specific transmitters. And again, early on in mental disease, we saw it really in depression as a good example of where that individuals would basically say, okay, it's dopamine only, or it's norepinephrine only, or it's serotonin. And in fact, with depression, we saw, like in the United States, they were focusing on norepinephrine. In Europe, they were focusing on serotonin. And people have now recognized that although there may be a primary deficit or a primary transmitter, but other transmitters may definitely be involved. And that is one of the reasons we've seen an improvement, I think, with regard to the therapy that we have for schizophrenia. So as you know, basically we see that there is, people have proposed that dopamine is the main player, but we've also had norepinephrine, serotonin, and even other transmitters, acetylcholine, GABA, endorphins, and then, as Jarle Gade listed, even NMDA that's being involved there. So we've seen a number of transmitters that have been promoted or suggested to be the thing. So let's take a look at dopamine first, okay? So one of the things that people, when you're trying to figure out mechanisms, you start looking for observations that may give you a clue. And one of the things that we knew about was that people that were developing, and not only people, but even in animal models, that when they were given high doses of amphetamine, or people that were abusing amphetamines, what they found was that there was that you could reverse this toxic psychosis by stimulating a dopamine, by using a dopamine agonist. And one of the other things that people saw was that there was, when they did these brain studies, especially on rats, they found that, and even some indirect studies they've done in man suggested that there is an elevation of dopamine 2 receptors. Okay, so when you look at this, the issue becomes that sometimes when there is a dopaminergic deficit, basically people, you get an increase in dopamine 2 receptors. So one of the things that came about was, okay, maybe there is a synthesis of dopamine that may be reduced. Okay, if dopamine levels are low, then and that causes the psychosis, then if we give a dopamine agonist that stimulates it, but and would reverse it, but then also it makes sense that, remember when we talked about upregulation and downregulation of receptors, is that when, if there's a reduction in dopamine release or synthesis of dopamine, then the body is going to upregulate. So that would account for the elevated D2 receptors in several of the brain areas. All right, let's go to the next slide here. So that started off, so there's been additional studies, and one of the things that they've actually discovered, and this is where this created an issue. So when you look at the concept, is that, okay, we know that there seems to be a decrease in the dopamine synthesis. So we recognize that there was a hypodopaminergia in the mesocortical neurons. So when we went in and we, took animal models or whatever, and or even sometimes in autopsy tissue, postmortem tissue, what we found is that the amount of dopamine that was in the mesocortical neuron seemed to be decreased. So that is a hypodopaminergia, which basically means there's decreased dopamine. But we also saw, interestingly enough, we saw a hyperdopaminergia in the mesolimbic area. Okay, so we got one area where it's high, one area where it's low. So knowing about behavioral studies, what we discovered was that the negative symptoms and the cognitive deficits seemed to be in areas which was related to the hypodopaminergia, okay, specifically in the mesocortical neurons. But think about this now. If you're put yourself back several years and you're sitting there and going, okay, I'm trying to find a drug. So it looks like if we give dopamine, that's going to help. But on the other hand, if we give dopamine, then it's going to make it worse in another area. Since we've got elevated dopamine in one area and I give dopamine, that's going to make it worse, whereas it'll correct the hypodopaminergia. So one of the questions is that, yes, all right, so we recognize that dopamine was a player here. But the question is really from a standpoint of what's really going on. So what do we do about the positive symptoms? So if we find that the negative symptoms were due to the hypodopaminergia, then one of the questions that we might want to be aware of is, what are we going to do about the other symptoms? So we found differences in the brain, but we also found differences in the symptoms. And so the question really comes down to, what are we going to do about it? Or how do we treat this? So one of the things, there was a group of drugs called neuroleptics. And by the way, just out of curiosity, what would your definition of neuroleptic be? If someone asked you to define neuroleptic, this term is used quite a bit, more so in the past. It shows up every now and then. But if someone, and I should say without you looking it up, biding time while you're waiting for somebody to respond, or that, that just off the top of your head. All right, so one would be antipsychotic, anti-seizure. It literally means taking control of the neuron. That's its, translation, if you will. But most people would consider a neuroleptic primarily an antipsychotic, okay? And so with the neuroleptics, basically we saw that the therapeutic effects of the antipsychotics, especially early on, seem to be that they reduce the dopamine function in the mesolimbic area, okay? So the idea was that those were dopaminergic blockers. And so that seemed to be where that is. Now, people would say, okay, so dopamine changes in different areas. So one of the things would be is maybe dopamine is sort of balancing the excitatory and inhibitory signals in different systems. We always we see people that discuss this all the time because it really comes into play that we see a lot of the neurons and the different transmitters, balance each other out, and they each can, some of these modulate release of others, and we see different levels and different responses in different tissues. So a lot of people like to take sort of the mid road and say, well, look, here it is. It's not really a lower high level. It's just basically the dopamine is important for keeping everything in balance, and therefore, it doesn't surprise me that it's low in one area and high in another area. That's just keep it in balance. But what we did recognize, dopamine has a play, and it seemed to be that it was that there was getting back to the previous slide, that it was really the symptoms, for example, was really what we saw with the current drugs was they reduced, but basically by reducing dopamine function. So the idea was the drugs that are working seem to be working, that we have an elevated dopamine, and what we're doing is by reducing that dopamine, especially in the mesolimbic area, that is what causes it, okay? So that's our thought process. But the problem is that that's in the mesolimbic area, but it means that we might either have no effect on negative symptoms and cognitive defects, or it may be minimal. So that was the issue that was coming into play. Now, I want to cover these pathways before lunch, and then I want you to focus on these pathways. I want you to review it at lunch, okay? So I'm going to go over these pathways, and then we will let you take your quiz, and then for lunch, I want you to watch that video, and I want you to re-look at these pathways. These are going to be, we're going to focus on dopaminergic pathways, and we're going to focus on 4 specific pathways, okay? So we're going to have the nigrostriatal pathway, which is A. So you can see that, let me get us an arrow here, would be better. All right. Thought my arrow was going to be a little bit better. Hopefully y'all can see this arrow. So the nigrostriatal pathway is going from the substantia nigra to the striatum. So you can follow this up. Here's the A. So it goes from here up here to the basal ganglia. Okay. Now, this one, the reason this is going to be important is not from a therapeutic standpoint, but more from not from an efficacy standpoint. This is going to be more of an issue with regard to the safety issues or the side effects, okay? When we look at another pathway is the mesolimbic pathway, so that's B. So that's going to come down here from around the tegmentum, and it's going to go up into here. So you can see B going up into here. And then C is the mesocortical, so it starts down here around the tegmentum. And this one is going to go up into the cortex, so mesocortical. And then we see a third pathway, which is D. You can see it right here that's right here around the tegmentum. And it goes right up in here to the hypothalamus, okay? We refer to this as the tuberoinfundibular pathway, okay? So there's 4 pathways that we're going to consider when talking about the pharmacology of these particular drugs, okay? And it's important because the differences between many of these drugs is going to be how they affect these 4 different pathways. And in fact, we're going to see a big difference between how these pathways are affected between the typical or conventional drugs and the new atypical drugs. This is going to be it. So when we're looking at this, therapeutically, therapeutically, what we're looking at is that basically these two pathways are going to be the ones associated with the positive and negative symptoms, okay? The mesolimbic pathway, that when you get an increase in dopamine, what that does is it increases the positive symptoms of the schizophrenia. The mesocortical pathway is if you get a decrease in dopamine, that causes the negative and cognitive symptoms. So think about this. You got two pathways that are going in opposite directions as far as the dopamine levels go. Okay? So from a standpoint of this, one of the problems is the initial drugs that we were talking about. One of the big issues was that we were saying the therapeutic aspects seems to be that if we can block the dopamine receptors, that will improve things. So what we would see is that by blocking the dopamine receptors, that's going to primarily affect the positive symptoms. By blocking the dopamine in the mesocortical area could potentially cause a worsening of the negative symptoms and the cognitive symptoms, okay? And in fact, we saw that in the typical drugs. We have no way of administering a drug where it would go only to the mesolimbic pathway and not to the mesocortical pathway, okay? Well, there is a way, but it would mean that I would stereotactically put a catheter in, and then I would address, basically I would run a catheter down through the brain to this area. So, basically, and I'd be administering through that catheter. There's no way we can do that. Okay. You're talking about long-term management. You're talking about, putting catheter in there. If anything, you possibly have to set up a pump. It's just not going to happen. So this is what creates the problems. And the reality of it was what we accepted was basically we'll block the mesolimbic pathway, and let's hope that we don't get too much of the mesocortical pathway. But the other problem we ran into is this nigrostriatal and this tuberoinfundibular pathway, they're dopaminergic too, which means that if I want to block this pathway, I'm going to block A, C, and D also. So what I want to do is if I'm using a dopamine antagonist, so let's just put D2 here, or D antagonist, I'll just use an A. So if I'm going to block, let me make it A and T so we know. All right, so I want to block it. So if I block this pathway therapeutically, then I got to worry about side effects from these three pathways. I feel like I'm working with an Etch-a-Sketch here, okay? So the conventional drugs, the ones we first came out, did this. They blocked the dopamine receptor. By doing that, they antagonized the positive symptoms. But by blocking the dopamine receptor in these other pathways, we had problems. We created problems, okay? That is a key point. This is what we're going to talk about, especially after lunch, going into, well, not only just after lunch, we're going to talk about it, a little bit later on today. We're going to talk about this. So literally, when you ask about, is this a dopamine pathway? Yes, we know it's a dopamine pathway. And the therapeutic aspect seems to be due to what we see is the schizophrenia tends to be in the dopamine. We're trying to take care of the positive symptoms. There's no way by just blocking the dopamine receptor can we take care of positive and negatives through that mechanism only. We're going to go into much more detail about that. Okay. So this is just sort of outlining what I went through. The mesolimbic pathway, we have hyperactivity. Okay. That is the basis of using a dopamine blocker, is that if the positive symptoms are associated with hyperactivity of dopamine, hyperactivity of the mesolimbic pathway, hyperactivity of the dopaminergic system, then the idea is let's shut that pathway down. And that will prove the positive symptoms. Okay. So from that standpoint, a dopamine antagonist would work. Okay. The mesocortical pathway. Here we have a deficit. We have a hypoactivity. Okay. That's associated with negative and cognitive symptoms. So we need to elevate that. We need to really elevate that. So we need to actually not, if we put a dopamine receptor, or if we block dopamine receptors there, that's going to make that worse, because that's going to make that hypofunction worse. Okay. So that's a key point there. So therapeutically, what we really need is we need a drug that blocks dopamine, but doesn't block dopamine. Blocks dopamine in one pathway, the mesolimbic pathway, but doesn't block dopamine in the mesocortical pathway. Okay. So a little bit of an enigma. One of the problems we had with the conventional agents. All right. Let's look down here. These are the other two pathways that we mentioned earlier. The nigrostriatal pathway. Okay, that's part of this extrapyramidal system. Okay, it's going to control motor movement. What happens if we block dopamine there? Well, see, normally we're not worried about it. I mean, in a schizophrenic patient, I mean, we really not that worried about the nigrostriatal pathway until we start treating them. Because then when we start treating them, if we use the dopamine blockers like we want to do up here, this dopamine blocker that we're going to use up here in the mesolimbic pathway, if we block dopamine receptors, the deficiency of dopamine in this pathway, which would occur, it was not really a deficiency in dopamine. What you're doing is you're blocking the dopamine receptors. So the dopamine that's there basically can't stimulate the receptor. So it's not really a deficiency. We know in Parkinson's disease there's a deficiency, but if we create a pharmacological deficiency by blocking the dopamine receptors, basically it creates movement disorders. It creates EPS. It also can create these hyperkinetic movements that we see in tardive dyskinesia. So our therapeutic, answer for the hyperactivity, in addition to not affecting the negative symptoms or possibly making them worse, also can produce significant movement disorders in the nigrostriatal pathway. And then let's look at the last one, the tuberoinfundibular pathway, okay? When you increase the neural activity, that basically dopamine inhibits prolactin release, okay? Now, if I block the effects of dopamine by using a dopamine agonist, like I would do up here to try to address the positive symptoms, what that does is it's going to increase prolactin release. So we get galactorrhea and potentially amenorrhea. So our problem is, one of our targets and our goals would be to treat the positive symptoms, is that not only does it not affect the negative symptoms, but may potentially affect the negative symptoms worse, make them worse, but it can cause movement disorders and it can cause galactorrhea. So one of the things that we'll do is, when we talk about pharmacology, understanding these pathways basically will give you an idea of the therapeutic strategies that the new agents basically are going to do, okay? Now, make a note with regard to this, because here's the questions that would possibly come up. I might ask you about whether it's hyper or hypoactivity in the mesolimbic pathway. Same question with mesocortical pathway. I might ask you which pathway is responsible for movement and what would happen with you have hyper or hypoactivity in this activity in the nigrostriatal pathway and the tuberoinfundibular pathway. So these two slides, actually think about this slide here, really just is a diagrammatic of the worded slide, or the verbal slide there. But make sure that you underline and you make this as part of your, as one of your key study slides, okay? Not only is it going to be important to sort of understand this, but it'll be extremely important with regard to understanding the pathways of the pharmacology of these pathways. All right. All right, let me cover this slide, and then we're going to let you take your quiz. That should be galactorrhea, Geraldine. If you look at the previous slide, at the very bottom, it should be galactorrhea here, and amenorrhea. So they should be at the very bottom of those two slides. Okay. Now, the next transmitter I want to cover, because we'll talk more after lunch with serotonin, because that comes into a much more detailed explanation. But one of the things that people thought norepinephrine was involved, because they have seen or observed that norepinephrine levels seem to be elevated in schizophrenics. As far as a mechanism, it doesn't appear that there is a mechanism. It simply may be that norepinephrines are elevated during a stress response or the general arousal. That could be, people have suggested, maybe due to an alteration in alpha-2 receptors. But as far as a specific player in the etiology of the disease and from a pharmacological standpoint, norepinephrine seems to have less impact than what we would see with dopamine. What you're going to see when we come back after lunch is we're going to put into play, we're going to talk about how serotonin is there, and then we're going to put into play the dopamine and serotonin. We'll touch on a couple of other neurotransmitters also. Okay. All right. So here's what, let me just reiterate everything for lunch. So Aiden's going to put your quiz up. There is one question on there, which could be a little bit tricky, and don't worry, just answer it to the best of your knowledge. It's question number 3. And because we will talk about that right after lunch when we go over the quiz. Okay. So I am aware that question looks a little tricky based on the way it's worded. Okay. Secondly, there's a 3-minute picture or 3-minute video on viruses that just shows you how they get into the cell. Just look at that at lunch. More importantly, at the end is look back over the slides on the key dopamine pathways in particular, those 2 slides, and let's see if you have any questions after that. Okay. All right. So we'll break for lunch. I'll see you guys at 1 o'clock. And we will go over the quiz, and then we'll pick back up on this. Does anybody have any questions? All right. And Aiden, I'll call you in just a few minutes. Talk about a couple other things.
Sure, doctor. I'll keep the poll on for 10 minutes before I close it.
Okay. And I'm going to go ahead and close out here.
Awesome.